exactly as, okay, got it. So, okay, so now we have to behave. Where to start? This is the second batch of COVIDX, and when I did this workshop last year, I combined more like the stakeholders in healthcare and the value proposition canvas. We had only one workshop that was 1 hour, including, I think, the questions and everything. And the feedback that we received and also what we saw was that it was simply not enough time. I had to rush through everything, and it still gave value to the startups, but it was not, as good as it could be. So this year we split the workshop in two. For each part, we reserved 1 hour and 30 minutes for Q&A, which is twice as much time and maybe a little more even. So let's see how that goes. Now I feel a little pressure because for each topic I need to give twice as much information, but I really hope and I really believe that it's not going to be only me talking to you, but that after some time it's going to be more of a discussion. I really would love you to ask as many questions as you have. Do not assume that the question is a stupid or a bad one. If simply something is not fully clear to you, either about what I'm talking or about how it applies to your business, please go ahead and ask. Christoph, I would recommend maybe to type the questions in the chat. Okay, so that then when we have a breaks after the sections of the workshop, we could go back to the questions. Of course, then I will say if a question pops up, then of course you can also ask. You don't have to type it in the chat. Yeah, so I think we have, as you said, like we have 1 hour for the workshop and 30 minutes for Q&A, so altogether 90 minutes. Let's see how it goes. If it's a little shorter, I hope that you will not mind. At least you're gonna save some time. Okay, looking at the names here, and this is something I would love. Could you please in the chat post the flags of the countries? Where do you guys come from, or where you are based? If it's two different things, I would really love to see, because when it's this international, it always makes everything more interesting. Okay, so we have Portugal, Greece. I am from Slovakia and based in Austria. We have Spain, Italy, Spain, Switzerland. Christoph, did you mostly prefer startups from the Southern Europe?
It seems so, yeah.
Okay, Canada, UK, Netherlands, Sicily, Greece. Awesome. So welcome everybody. I think that based on this we see, like, we started talking about weather, of course, and I can imagine we have all types of weather, from sun to rain to hopefully also snow somewhere, maybe in Sicily. Let's go. Let me share my screen. Here. Okay, it's okay. Again, I need to go to the settings.
You have disabled the share screen.
It looks like, I mean, I have a new computer, so, but it should be already No, I mean I have enabled sharing screen, but okay. I really apologize for this.
From technical point of view, I can once more make you a co-host, maybe to.
No, it's not a problem of Zoom, like of the meeting per se, but it's a problem of my Mac. So okay, I'm getting there. I'm getting there. Okay, this is really Kristaps, maybe to save some time, would it be okay if I shared the slides with you and you shared the screen?
Of course, no problem. We can do so.
Awesome, perfect. Thanks a lot. Okay, I sent it. You should have seen it in your email. And I promise that for the second workshop, I'll fix this.
Okay, so now I'm getting there. I will have presentation in 30 seconds. Okay, we're ready.
Okay, it's coming up. Perfect. Awesome. Thanks a lot, Kristaps. So a little bit about my background, and again, I apologize for those issues. I'll make sure that next time it's going to be super smooth. I've been working in digital healthcare since around 2013, when together with my co-founder, we co-founded Mentegram. Mentegram is a digital health solution for optimizing mental health workflow or efficiency of mental health care. And when I think about it now, 2013, it was way too early to start introducing digital healthcare solutions. Even though our main or our focus market was in the United States, because it was still the time when mostly the clinicians and hospitals were adopting and getting used to the electronic health records, and our solution was like the next level. So the first years were really tricky, and actually after some time we left the US market and moved the operations and sales and everything out, refocused to Australia. That was a few years ahead of the United States, and it was also the time when I left the company, because from Europe I could not really support Australia anyhow. So now the company is operating there, has a new CEO, and even though it did not do like the typical hockey stick growth as everybody would want, it's doing quite well. When I left Mentegram, I joined mySugr. I stayed in healthcare. mySugr was a very successful Austrian startup that was acquired by Roche in 2017, so 1 year before I joined. As you can see, like on the picture, like the motto or the goal of the company is to make diabetes success. So, but what mySugr does, it builds digital solutions to simplify life for the people with diabetes, because if any of you either has diabetes or know people what they need to do, it's a very, very difficult life with really having to make many decisions and considerations on how to behave and what to do, how their activity impacts their blood sugar. And at mySugr, our mission was to help those people, especially, and those like two of the co-founders had or still have diabetes. At mySugr, I was head of therapy solutions, meaning that I was responsible for building those solutions. And last year, I decided to leave the company. It was a good time, and also, as Kristaps mentioned, we got like our second baby was born in November, and I was thinking that this is time that you cannot really get back. So now I'm spending most of the time with my family, and as a side, I'm supporting COVIDX and one more accelerator also driven by Civita. In 2017, I also published a book that I started writing maybe in 2015 even, and it's a summary of my experience from Mentegram about how I started a startup, what I had to go through. Is really in the very first stages of a startup, from getting the idea to the first pre-seed or seed fundraising. The book doesn't tell you how to exit the company because I haven't done so yet, but it tells you how to validate the idea, how to build value proposition, and how to start selling. And part of that is what I'm going to talk about also today. Right. Okay. Next slide, Kristaps, please. I will have to. Okay. So this is the agenda for today. First, and especially in healthcare, it's important to think about or to differentiate between who are the users and who are the customers. So in the first part, I will talk a little bit about that. Then in the second part, it's going to be probably the longest, I will talk about the typical stakeholders in healthcare and what's their motivation and what they want to achieve. And then in the end, I'll summarize it and maybe give a few hints on how to understand who might be your stakeholders, how to figure out how to work with them. Okay, so let's go to the first part, users and customers, and let's do it like this. If you have any questions, as I mentioned, like while I'm talking, please put them into the chat, and after every of those sections, I'll pause for a bit, answer those questions, and if you have any more questions, you can also ask directly, and we'll talk about it. Since we have 90 minutes, we have enough time to talk about really everything that comes on your mind. So it should not be any problem. Okay, users and customers in healthcare. The reason why it's tricky is because the users are not always the customers. It's not like the usual most of the applications. So of course, the first use case is that when users are the customers. What means that the end users are the ones who are also paying for this. It's often the patients paying for some rather more simple solutions. For example, in the case of mySugr, it would be like people paying for a pro version of the app, but it's like for a monthly subscription for a few euros, or possibly also it could be the doctors paying for some patient management system if those doctors are private practices. However, in most of the cases, when user is a customer, it's not really healthcare solutions, but it's more often some kind of wellness or lifestyle apps. It's not, of course, it's not a rule, but most of the B2C solutions fall into this category. Many of you, I believe, know, for example, 23andMe DNA test. This is from my perspective, a very good example of a healthcare B2C solution where the end users are also the customers. Like no one else is involved. But then when you think about the apps that go more to the wellness direction, there I see the fitness or meditation applications like Runtastic, Also, mySugr, like the one part of mySugr could be there. Headspace, Calm, and all this that help you improve your life, help you get, help you with nutrition, with meditation or something, but they are not really medical devices or medical apps per se. And with this, of course, I'm not saying that they are not good or something. It's simply a different category. And then I already mentioned the types of solutions where the users can be the customers are often doctor office management software for small practices, especially when it's when the doctors are not part of a hospital or a clinic, but they have their small office. Maybe 2 or 3 doctors are there, a few nurses and some receptionist or some admin staff. Then the end user is a customer, because like this doctor or this small office pays for the solution, and they're also using it. And in this case, everything is, comparing to the other use case, very much easier and much more simple, because you have only one. In most of the cases, you have only one stakeholder. You have one person to talk to learn about their problems, their jobs to be done. This is something that I'll talk more about in the next webinar. And therefore, it's much easier to build and create a value proposition and build something valuable for the customers, because you do not have to consider many different types of users. Okay, let's go to the next slide. Much more usual, sorry, the previous one. You skipped, yes, this one, thanks. Much more usual solution in healthcare with digital solution is that users, meaning the end users, are not the customers. So it means that someone who, like the ones who are using the solutions, are not the ones who are paying for those solutions. Often, the ones paying for these solutions are the insurance companies or the payers in any case. If, like in Europe, of course, it's mostly the insurance companies. In the United States, it could be also the employers or some other organizations. However, those insurance companies are not the end users. They do not really use it. They pay for it. But then it's the healthcare professionals using one part, the patients could be using another part. Really, this is the complexity of the healthcare solutions, and this is the complexity from my perspective, of why for startups in healthcare it's much more difficult than in other industries, because this complexity leads to much more uncertainty, and this uncertainty leads to potentially longer times to figuring things out. And this still does not include the regulatory part that many of the medical or healthcare startups or healthcare companies need to go through. The reason why it's like this is that, and especially again in Europe, people are not used to pay directly for healthcare. We usually pay healthcare insurance, and then the insurance company pays sometimes all of it, sometimes to a certain level, but covers our healthcare. And therefore, there needs to be a value proposition for the insurance company. And of course, because of that, there is ultimately only one value proposition, and it's to have a healthier population, because then then the healthcare costs are going down and the quality of life is going up. So somehow the value proposition that you are creating or that you are building needs to go this direction. Of course, if it's a solution that is not focused directly on the patients, but for example on the clinicians, there as well, if they are more productive, then the costs are reduced, and more productive clinicians mean that they can provide care to more patients, which means again that the population will be healthier. So, and it's always good to think about from your perspective, from the perspective of your solution, what the healthier population means, right? Because for someone, as for the payers, it's, as I said, like as harsh as it sounds, for the payers, it's simply lower cost for healthcare. But then for the clinicians, it could be easier life, or not being that busy, not that overwhelmed, and especially with COVID with the past 2 years. I mean, it's much crazier than it was before. And for the people, simply when they are healthier, they have better quality of life. They are happier because they do not have problems, whether kind of like single occurrences or chronic issues. They do not have to go to the doctors. They do not have to spend money on medication, and so on and so on. So this, when users are not customers, this is where the complexity of healthcare and the solutions is coming in. Okay, let's go to the next slide. And this was the more of a, I would say, introduction. So I see that there's something in the chat. Okay. So the question, mySugr is a great example of B2C. How you minimize the risk of losing patient focus when you get integrated into a company with a very different culture? Luis, it's an amazing question. And thank you for that, because actually that was a topic. And now I hope that I'm not talking about something that I'm not supposed to, that is supposed to be confidential, but I believe not. That's something that actually we have been talking about at mySugr a lot as well. That Roche, as an insurance company, like they are very, as any company should be, they are very business focused from the perspective that you do not want to invest into solutions or projects or products, however you want to call them, that you believe are not profitable in the time frame that you want them to be profitable. Whether it's 1 year, 5 years, 20 years, it depends on the strategy of a certain company. So it means that from this perspective, I would say that how I understood it was that, of course, there are parts of solution that are patient focused or patient centric, but they do not bring direct business value. So it means that you cannot really quantify or estimate how certain solutions or features impact your business, other than retention. But then there is another part of the solutions that are also patient focused, that actually you can link to the business cases, you can link to retention. And this is how I believe this should be addressed, that for every solution, like when you think about how many questions or requests you're getting from your users, it's impossible to implement all of those. It's impossible to implement half of those. So you need to be we need to prioritize a lot.
Yeah.
And yes, go ahead.
My question was, because I have been working mobile health for from my master like 15 years ago. So I have been actually following mySugr, and I think one of the key messages is that mySugr doesn't focus so much on the disease. It's very patient centric, even the communication, because diabetes has to be less. It's not disease focused, but more like I empower the patient to just take control of diabetes as any other thing in life.
Yeah.
But you go to any pharma, and not Roche, all of them, they are very disease focused. So it was also the culture of how you see the patient, because one point of view is a person that needs to be empowered to take control of their health, and we bring them technology. versus more the therapeutic or diagnostics that is way more disease oriented?
Thanks, Lucy. Yeah, that's a good point. So I cannot say, of course, for everyone else, but when it comes to the communication towards the patients, this is something where actually Roche, I believe, did not negatively impact mySugr. That mySugr is still keeping this patient-centric communication and building everything around the patient needs, around empowering, exactly as you said, empowering the patients, the people with diabetes, to simply make their life easier. While when it comes to prioritizing for the product features or how the product is going to be developed in the future, that's something that has to be aligned, and that has to make sense also from the business perspective. You know, one example for all, I would say, the biggest project or the topic that I was working on was mySugr pump control. People with diabetes, mostly type 1 diabetes, they can inject insulin in two different ways. Either they use a syringe, so they inject directly with insulin pens, or they use insulin pumps that is attached to their body. And when needed, like they either on the pump itself or on a specific device that controls the pump, they simply program insulin delivery. With the mySugr pump control, we built probably the first pump control that could control the pump from a mobile app. So it means that the people with diabetes do not have to wear like this specific control device anymore. And when you look about it from this perspective, it makes business sense, a lot of sense from the business perspective, because it's supporting the sales of the insulin pumps, while it's really patient-centric, because it makes the patient's life much easier by not having to wear this extra device. And also there is a lot of stigma about diabetes and people, like using some strange device when they are in a restaurant, comparing to using their phone. I mean, like everybody probably uses their phone when they are sitting in a restaurant. So I would say that mySugr, like from this perspective, the mySugr got better business focus while not losing the patient, being able to empower the patients with this acquisition by Roche. Okay, Jose Maria, I might be wrong, but I believe that in Europe, there is no strong opportunity to exploit a long tail business and to a point a blue ocean model. So we are kind of forced to play a Pareto game in a mostly red ocean, which is hard for most startups. So if the product is not unique and highly needed, most of the chances would need to go hand in hand with the big player, or maybe shoot first at the private healthcare place. Could you, Jose Maria, could you clarify a little what do you mean? Like when you say, especially when you're talking about the long tail business in this case, could you give me some example?
Yeah, what I mean is that at the end of the day, public healthcare is going to go for I wouldn't say the lower cost, but the solution that fits the most, right? So instead of playing in the US, where you can find many different insurance companies with many different levels, right? You have more opportunities to find a long tail, right? A very different niche with a set of needs that you can address. You can make the numbers, right? But in Europe, it's a little bit harder to find that because of it's public healthcare driven. So especially if you're a startup, you have not, let's say, the commercial power already established. It seems like it's easier if you are addressing a long tail to firstly shoot to those insurance players in private health institutions to gain your position there. And thinking on public healthcare, it seems a better strategy to try and make some partnership with some big players.
Thanks. Yeah, I mean, I would say yes and no. From the perspective that, yes, I fully agree that for a smaller startup, it's extremely difficult to get refunded or like covered by public health insurance. Even for mySugr, after the acquisition, it was a lot of work and a lot of effort. However, in the United States, when you think about the biggest insurance companies in the United States, like Humana, for example, for a small startup, it's close to impossible to get there as well, unless you're a solution that makes the use of certain insurance reimbursable costs that are there. Then it's only about selling it to the end users. What mySugr did, for example, was that with the B2B model. Sorry, I could hear some background noise from someone. Could you, if you're not talking, could you mute yourself? Andy, it was you. I muted you. So, for example, mySugr did exactly this. That when they started with B2B sales, they sold the solution to the private insurance companies in Germany. And this is another complication actually in Europe, because every country in Europe has a little different setup. For example, if you go to Germany, you have public health, but then you have also private health insurance, which is quite complex, covering healthcare quite well. When you go to Slovakia, for example, I'm mentioning it because I know that market quite well. There are 3 public health insurance companies, and that's kind of it. Yes, then you have private insurance, but it's not private health insurance, but it's a life insurance and similar, and that's completely different. Okay, Jose, I have 2 questions. One is about to understand your view on how to go from an R&D project to commercial product. Second question, how to introduce in reimbursement process a new innovative product. Good question, Jose. The first question about the transition from R&D commercial, it depends a lot on what type of product you have. If the product is a high-class medical device that cannot be commercialized, before getting the CE mark and getting audited and everything, then it's much more challenging, much more difficult than without it. Because usually, I would start commercializing the product one day after I start with R&D. Because, and in the beginning, when I talk about commercializing a product, I'm talking more about, not first directly selling a solution, but rather learning about the problem that I'm solving. So meaning that with that, I have a hypothesis that there is a problem, that certain stakeholder group has a problem. And then I need to talk to those stakeholders and validate whether my hypothesis is true without mentioning my solution. When I validate it, this is the first. When I validate it, then I can start talking about my solution. While in the R&D track, keep building the solutions, using the learnings from this validation to make sure that the product is really addressing real needs of the real stakeholders. And if you do it, like this and hand in hand, it's gonna be much easier, because when the product is ready, you already have certain network of the people who are potential customers, potential affiliates, and so on, to who you could either sell the product, or who could help you, selling the product or marketing the product, getting it to the press and similar. Depends on what kind of product. If the product is a higher class medical device and especially that needs a longer R&D, when it's not a digital solution. For non-digital solutions, it's even more complicated. And then you are a little limited with this, of course, because you cannot bring things to market like that early. But I believe that you still can, keep validating those problems that let's say that I'm building a let's say with diabetes. Let's say that I'm building an app that's going to automatically inject insulin based on that there's going to be some artificial intelligence or some algorithm that from the picture would understand like how many carbs I ate, from the fitness tracker would understand how much activity I do, and would crunch the numbers and inject the insulin based on those numbers without the user having to do anything. This is a high-cost medical device that can kill a person if something goes wrong and injects way too much insulin. This can really kill a person. However, so it means that this cannot go to the market before it goes through all the regulatory mumbo jumbo that it needs to go through. On the other hand, though, from the very first moment, you can start working with the community, with the people with diabetes, with the clinicians, with the key opinion leaders, on understanding what is the best approach to build this, to make sure that also the user experience is good, to make sure that you understand the problems that fall here within this scope, and therefore that you can address those problems that you need to understand your users. So this is for the first question. If there is something more, just let me know. Second, how to introduce a reimbursement process. In the reimbursement process, a new innovative product. This is something that I cannot. I'm afraid that I cannot really answer because I do not have any experience with this in Europe. But in general, I would say that if there's something completely new, you need to find a way how to talk to the insurance company, because the insurance companies are the ones reimbursing. And there you will see, but at least from my experience, which is very limited, of course, if it's something completely new, it's extremely unlikely to succeed unless you are someone really huge or really big. Because for an insurance company to introduce a new reimbursement process or something very new, it takes a lot of time, and it's also a lot of admin work.
Yes, thank you, Milan. Because in fact, so the first question, it's similar what we have done till now. So we have a remote patient monitoring system for chronic patients. Of course, now we are also with COVID patients at home. So our goal is to monitor patients at home and build the hospital at home. So that's what we do. We start, as you told us, so we start with some POCs in heart failure, then COPD and diabetes, and now COVID. We are certifying the platform as a class 2B, so that is hard because, of course, we have ready. Now we have the cases and published cases, but in fact, we need to go to the certification process, and that takes time also and consume time and resource. But now when we are finishing now the certification process, because we already are in the ending of that process, the point is about the reimbursement. And what we see in Europe, starting in Portugal, is that there's no reimbursement process, neither in public sector or in private side. So it's quite challenging for us when you have a very impactful platform where you can reduce costs for insurance, going up in quality of life, like mySugr does, right? And then you go to a payer and they say, okay, but we don't have this in mySugr, right? And you go to the hospital, they say, okay, but this is not also here in mySugr. So that is something that, of course, I think that is my bottleneck today.
Yeah, I see. Yeah, and I mean, it's a super challenging situation.
Yeah.
I'm not going to say it's not. I would recommend to find a way to talk to some someone from the insurance companies, whether public or private. I would say, depending on the country, it might be easier to get into private. Somewhere it might be easier to get into public.
Yeah, sure. Thank you.
So,
yeah, thank
okay. Thank you for asking. Okay, Thanos, I'll take this question as the last one, and then I will continue with the typical stakeholders, because actually the time is progressing quite nicely and much faster than it feels, to make sure that we'll go through everything. So your question is, mySugr partnered with insurance providers and was acquired by a pharma company. Would an insurance company also be a candidate acquirer? Would the Roche acquisition have been different if you had partnered with Roche instead of insurance companies from the start? And if you had partnered with Roche, would that have reduced your likelihood of insurance partnerships? Okay, so I will be very quick because I can only speculate, because I joined mySugr after the acquisition. But what I know for sure was that mySugr actually partnered with Roche before the acquisition. Because through the mySugr app, the people with diabetes could order the Roche AccuCheck blood glucose meters. So this was the partnership. And actually, my assumption is that this was one of the reasons why Roche acquired mySugr, that they actually saw mySugr as a potential patient-facing or go-to-market strategy for their devices. I'm not sure that an insurance company would actually be a good acquirer, because I'm not sure how many insurance companies do provide such digital solutions directly. I think that the insurance companies mostly reimburse or pay for those, and very recently it's pharmaceutical companies that have started to move more and more towards the digital space. So it means that they are not building, or they are not providing only medication or some devices to the patients, but additional layer of digital services to the patients or clinicians or both, that make their either devices or medication, that together it provides more value. So this was good. One second, sorry. Okay, so let's go to the second part, and it's the typical stakeholders in healthcare. And yeah, if you have any questions, please keep writing them. I really like it that you ask a lot of questions. Okay, typical stakeholders. Kristaps, next slide, please. And the first, most usual, is patients. And I mean, I have already, and especially in this during this discussion, we covered this a little, but I would like to make sure that I summarize it so that it's clear. The first and most usual group of the stakeholders in healthcare are obviously patients. And with patients, I mean people who, not only the people who are sick or ill and have certain health issues, but also people who want to prevent their health issues. So it means that it's, with the patients, I mean people who have some chronic conditions such as diabetes or something else, but also non-chronic conditions like COVID or simple flu, who break their arm, simple like anything. But I mean also, prevention. For example, if someone is using, let's say, a digital mental health solution to rather prevent from falling and from getting depression or anxiety, or if someone is using fitness and nutrition apps to prevent, to keep healthy lifestyle, to prevent diabetes or not to become obese, having problems with blood pressure and similar. And in many cases, of course not all of them, patients would be the end users of your solutions. Of course, not only, but in many cases. Okay, let's go to the next slide. Then the second big group who much more often end up being users rather than customers are the healthcare professionals. And with those, I mean any professional providing services to the patients, not only the doctors, because in healthcare we have doctors, nurses, therapists, some supporting staff, admin staff, again, like depending on the setup of the institution, on how it works in the country. Is it public? Is it private? And there might be solutions that where only the healthcare professionals are the users. For example, electronic health records where healthcare professionals like track the patients. But there are many solutions, and actually I've seen that this type of solutions is growing, where both healthcare professionals and also patients are the end users. And here I'll use Mentegram as an example. How Mentegram worked was that for the healthcare professionals, it provides a digital dashboard where the clinicians can manage their patients and see their mental health data. And by that, I mean that they could assign various mental health questionnaires and scores for the patients to fill out. So this is the part where the professionals were using. They could see the progress, they could track the patient, they could see reporting. For the patients could use either their mobile phones or computer or kiosks in the doctor's offices, again depending on the specific use case, to fill out those questionnaires, those assessments, to provide the information for the doctors. So it means that the end users are both healthcare professionals and the patients, and it's mostly in those cases it's about getting the data and more and better data from the patients to the healthcare professionals, so that the healthcare professionals can make better decisions about the treatment, about the care that they are providing to the patients, which is ultimately leading to better health outcomes for the patients. This goes the way that the care can be much more personalized. That it's not like every person with depression is the same, and you get every person with depression like Xanax and therapy sessions once a week and that's it. But based on this data, you could optimize and personalize this treatment to make sure that the patient gets better faster, or that the condition does not deteriorate more than it would if it was not personalized. Let's go to the next slide, please. Then the third big and significant stakeholder are the institutions. And with the institutions, I mean the organizations mostly who are providing or who are kind of organizing, or who are the umbrella for providing healthcare services to the patients. So it means here I think about the hospitals, health networks, research organizations, professional associations, and similar. I would say that hospitals or networks of hospitals are the most usual institution here, because when you are building or doing a solution that addresses certain conditions, and often if you're going through public health, but that doesn't matter that much actually. If you do not go to the individual clinicians who are individual private providers, many clinicians and healthcare professionals work in the hospitals, and when they work in the hospitals, they cannot really decide on which digital solutions they will use with the patients. It's on the hospital to decide and to implement this for the healthcare professionals, and in case patients would be using it as well, also for the patients. So it means that that those institutions, they need to see that those solutions that the clinicians and the patients would use to improve health outcomes, that it would be mostly cost beneficial, that it would not lead to for the clinicians or the nurses to spend twice as much time because they need to document everything also on the computer, but rather that they need to see that the productivity of their staff is gonna be better. It's gonna grow. And and now now you start seeing that each of those three, the value that they are looking for is different. Patients, it's better health, not having to do, and ideally not having to think about it. For the clinicians, to be more efficient, or to be able to provide care to more people, or better care, not to get better access to data about the patients. And for the institutions, since they are public or private businesses, it's again, as harsh as it sounds, it's falling to the cost. So it means that the operations need to be more cost effective, and digital solutions need to help them with this. And now if we go to the last slide, and the last stakeholder, of course, is the payers, who are in most of the cases end up paying for those solutions. And in Europe, of course, it's mostly insurance companies. And then, as we talked about, depending on the country, it could be either on the public insurance companies, but also private insurance companies. In the US, it's mostly private insurance companies, of course, but then also the payers are not only the insurance companies, but also in many cases employers. And here's again a big difference. I don't know how many of you are in the US market or are planning to go to the US market, but the big difference between Europe and US is that in the US, employers, especially the big ones, often act also as health insurance. So it means that the employees of those companies get health insurance from the company instead of from the regular health insurance company. What makes the employers payers equal to the insurance companies. And this is really very interesting from the digital solution perspective, and also from the sales perspective. This is really very interesting because while insurance companies, their single focus is to reduce healthcare costs. For the employers in the US, there is one more leverage, because they not only want to reduce their healthcare costs, but if their employees are healthier, they are also more productive. So it means that there is this leverage. In Europe, it's a little different, because the employers do not pay for healthcare like this. However, many companies, and especially the bigger ones, they have various employee benefit programs that might provide such solutions. For example, there might be a company, or under those programs, for example, people could have access to mySugr, so that they would not have to pay for it, and their diabetes would be better, and so on. Of course, the big difference from my perspective, a big difference between the employee benefit programs and regular healthcare is that the employee benefit programs, it's more nice to have. It's not something that the employers have to do, also that the employees have to use. So it means that if it's something that you would try, or you would go this direction, I think that it could work, but it could be easier to sell it to an employer. However, it would be difficult to activate the users. It would be more difficult, for example, from the eligible population, if it's in healthcare, you would get more users and retain more users than within those employee benefit programs. Okay, this was the last slide from the second part, so I'll pause a little so that you can digest all of this. I see that there is one more question, and then please hit me with questions, and especially with the challenging ones. Is someone okay? So it was not a question, Stanos. It was more of a comment that if someone wants to research, please check out self-insured employers. And is this actually something that works also in any country in Europe? Do you know? Or because I haven't heard about it in Europe, only in the US. No, not true in Europe. Yeah, okay. But for example, for example, so one of a B2B offering that mySugr has is together with Roche is a little more complex, and that's what mySugr is selling mostly in the United States, and actually mostly to the employers. And it's what is called the mySugr bundle. So it means that it's not only the app and the pro version of the app, because it would be quite a cheap or cheap-ish subscription, but it's a bigger bundle, bigger package for the people with diabetes that they need to use, that makes their life easier. And it's combined, of course, of the pro version of the app so that they can use everything, but also of the diabetes supplies. So it means that the blood glucose meter and the test strips, so that the people can get easy access to this and measure blood glucose really easily, where especially in the US, it's much more difficult and quite expensive to get those supplies. And the third part is diabetes coaching for the people who have any questions about their diabetes, how to manage their condition, to have a coach that they can reach out to and and get support, because the people with diabetes usually have check-ins with their doctors every 3 months, but in between they do not get any support unless they need a medical attention. So for example, if a person with diabetes wants to run a marathon or something, this is a use case where a coach could be really very, very helpful to help them understand like what happens with their body during the marathon, how to manage blood glucose, because that's quite tricky. And actually I had a colleague who has diabetes and she ran a New York City marathon, and when I think about it, it's quite amazing, because like the number of calories that you burn, like the number of like the amount of sugar that you burn to keep it.
Όταν έχεις δει το κάμερα ανοιχτή, έχεις δει ότι μπορείς να εμφανίσεις την προφίλ της Pixel.
Sorry, Kostas, could you repeat?
Can you repeat your question, or it wasn't a question? I get it. I guess it wasn't a question. Yeah.
Yeah. Okay. Okay, cool. So if there are no more questions, let's go to the summary. I mean, we have still 30 minutes, so if there are not too many more questions, we could end a little early. It's completely okay.
Well, from my takeaway, maybe that what's my idea, what I was able to get out of it, that if you have a new product, then of course the fastest way how to validate it could be patients as stakeholders and doctors as individual practitioners, because you can get feedback quite fast and you can reach them easy. But again, if we talk about especially in Europe, about institutional stakeholders and especially insurance companies and hospitals, then it's quite a long run, right?
Yes, exactly, and that's exactly as you said, and this is where the complexity of healthcare is coming in, because, and actually, Kristaps, that's a very good kind of like segue and bridge to this last slide and to this summary that I wanted to talk about, because I'll put it this way: if it's a solution, and in many cases it is a solution that would be somehow reimbursable, before you go to the insurance company, usually you would need to have some data, some evidence that your solution, really brings value, which means reduce cost, would reduce costs for the insurance company. In order to be able to achieve that, first you need to talk to the patients, talk to the clinicians. Ideally, if it's possible, have some pilot program, or or doesn't have to be pilot program, could be like a real program, but maybe not reimbursed, or finding a way how you could, if you're financed, if you raise money from the investor, like you could run it also. Sorry. You could run it also, like without any revenue, or you could do a clinical study with a population who would use a solution, and then a population like would not use a solution to compare it. And then with this data, if you go to the insurance company, it would be much easier. Of course, but there is a big gap between getting this early validation, and talking to the insurance company. But in between, there are many other options how you could get, I don't want to say validation, but rather guidance or direction where it's doable, it's not doable, or it would be doable with the insurance companies. For every health condition I believe in any country, you can find some key opinion leaders who would be or should be quite happy, or to talk to you, to give you some feedback, or some mentors who already have experience in certain area, in certain country with insurance companies. Some people who already has been through it. It would usually be easier to reach out to those people to get some more insight into what does it mean, and how to get to those insurance companies, and how to get this feedback. So if I was you, and I would have troubles reaching out to the insurance companies, I would either actually, like now talking to the startups through this accelerator, like through COVIDX and through Civita, I would really push hard on Civita to use the network to get you in touch with the people who you need, because Civita has offices across whole Europe. I mean, not every country, but in many European offices. So it means that Civita's network is really, really big, and it's very likely that there is someone in the network who could give you at least partial information to the problem that you have. And then it's also important when you're doing this to challenge the person who is giving you the information, because sometimes those people mix up assumptions and facts. And in healthcare, it could happen that people mix up assumptions and facts. So when you talk to those people, always make sure that you understand whether what they are talking about are assumptions, that some of the things that I said today as well are more than assumptions, like saying that for the health insurance companies that it might be easier to go through private first and public second, and so on. So always make sure that you understand like what is an assumption, what is a fact. And if you prepare for the meeting well, then it's likely that the person could link you to someone else who could even better answer your questions. And this way you would kind of like network up to the person who you end up meeting. Yeah, it's usually it's not fun, it's time consuming, it's tricky, but in many cases it's the only way to do it. Okay, so and with this, with the customer segmentation, often, especially in the beginning, and I will use example of Mentegram. Who should I work with? Like, so who are the stakeholders out of those 4 groups? And potentially there might be someone else, but usually there is not, who are the stakeholders that I should work with or that I will work with. It's good to understand it as soon as possible. Usually it's not, usually you will not get it from the very beginning. For example, what we did was that initially we were building a solution and we wanted to sell it to the psychologist to better collect data from the patient. So we built a solution. So we started talking to the psychologists. We built a web dashboard. They kind of liked it, but it was not a must for them. But soon we realized that, okay, but in order, they had problems that even though they wanted to use it, many of their clients did not actually use Mentegram to collect the data. So then we realized, okay, so we have another stakeholder, is the patients, and we need to make the app that is easy to use for the patients so that they would use it. So we improved, there. Soon after, we realized that when it comes to the value proposition, we did not create enough value for the psychologists. So we had to go more to the medical area towards psychiatrists, and then it started involving the insurance companies. So it's already the third stakeholder. And now in Australia, also the hospitals are involved as fourth stakeholder. So this is something that it's good to understand, like this journey, this evolution of the stakeholders that you are going to work with as soon as possible, because then it's gonna save you quite some time and troubles that we learned the hard way. And I have 4 questions actually on the slide that should help you a little at least, because ask yourself those questions and do not think about the solution first, but the question. So like, what problem are you solving? And for example, let's talk, we are in COVIDX, so let's talk like and let's be very generalistic, you are solving something with COVID. So that's the problem. Who has this problem? Of course, the patients have COVID, so they have problems. However, the clinicians, they also have problems because they are overworked, overwhelmed, way too many people are hospitalized. They are pulled maybe from other, from other parts of the hospital to the COVID intense stations. Third question, who is using your solution? So is it those clinicians? Is it the patients? Is it someone else? And then fourth, who is paying you? Who of those stakeholders is paying you? And how do you get money? When you answer those questions, then you will see that it's going to be, for example, who has these problems? It would be patients, clinicians. Who is using your solution? It's patients. Who is paying you? Insurance companies. Then you have 3 different stakeholders. So, and in most of the situations, there is going to be more than one. And if that's the case, as I mentioned before, like for each of the stakeholders is looking for something different. So it means that for each, that you would need to understand each of those stakeholders, and then for each of those stakeholders, create different value proposition to make sure that they see the value in the solution and either pay for it or use it. Like when it comes to how to understand and create the value proposition, this is a topic for the workshop next week, right? And then, so there I will talk about the value proposition canvas mostly, and how to use it to create and to build value proposition. And I also I prepared like a small exercise for you there, which last year helped a lot. And maybe how I'm gonna finish, it sounds quite complicated when like stakeholders for this, like stakeholders looking for that. Think about, someone said, what's your favorite food? Pizza, burgers. Let's go with pizza. So let's say that you're going to a restaurant to have pizza. For typical solutions, like what you would do is that you find a restaurant that you want to go to. You go there, you check menu, you find what you want to eat, you eat it, you pay for it, and you leave. Simple, usually. However, healthcare, but imagine that this restaurant visit was healthcare, it would be a little different. You still need to eat your hungry. However, there will be someone who picks a restaurant for you, someone who tells you, hey, go to this restaurant. When you come to this restaurant, someone else will order a meal for you. It's not going to be you. Then you are going to eat the meal, even if it's a pizza with pineapple and ketchup on it. And then someone else is going to pay for it. So it's those 4 different stakeholders. And the restaurant needs to make sure that all 4 are happy, that all 4 see the value in this restaurant deal, instead of a very regular use case when you as one person simply pick a restaurant, pick food and pay. And with this, I'll close like this, the slides and this part, because I believe that this is a very easy way that explains the complexity of healthcare. Of course, I don't want to scare you off by this, but rather help you understand that it's quite challenging. However, once you figure it out, once you get there, it's going to be, at least for me, it was much more rewarding than something else. Okay, we have 15 minutes left, so time for more questions.
Exactly. So what about questions for our audience? Do we have any? For me, for sure, I guess the tricky part, as you already said, is that usually it's like one stakeholder, so one value proposition. But here exactly you have users and then you have payers. And these value propositions, of course, they can be not the same.
Yeah, well, I mean, they often are not the same, I would say, especially when you think about the doctors, patients, and the insurance companies. Yeah. Because when I put it simply, with Mentegram, the value proposition for the patients was to better engage with their therapy. Because when you have mental health issues, or depression, for example, you're not really, you're not motivated. So like doing something on your own without the clinician support is much more challenging than without a depression. So there, the value proposition for the patient was to help them with this. The app would have some very sensitive, of course, but some reminders or some either education, or exercises that the clinicians prepare for the patient, so that the patients could do this. For the clinicians, the value proposition was completely different. For the clinicians, it was to get better information about the patient, especially for the medical part, and to understand which of the patients are potentially getting close to critical phases. So it means that to understand to which patients they need to reach out first, and also to find an easy way to have an easier way to create the therapy or care plans. For the insurance company, again, like simple, reduce costs.
Exactly. I know that for some solutions we have hospitals as paying customers. Maybe you have some experience with selling to hospitals, like how long it usually takes, like 6 months, 1 year, or like 10 years?
It's a good question. It's very specific, I would say. Definitely, it's at least months of time from my experience. But again, like my experience is coming mostly from the US. I haven't sold anything in Europe. But in general, like selling to institutions both in the US and in Australia, it's taking months, sometimes even more than a year. often because the institutions, when they want to have bigger solutions, you know, if the institutions do not have budget for such solutions in certain year, they simply cannot do it. So it means that they need to budget it for the next year. So this adds complexity and time. But also those institutions, like they have to do quite a heavy due diligence on the solutions. So it's not only finding a doctor or a lead for certain condition to, you know, to sell it to in a hospital, but it needs to go through the, you know, you need to get an approval, of course, like the medical approval. You need to get approval from some kind of like chief information officer, you know, like that the solution, like the technical part is okay, that it could be potentially implemented into the solutions that the healthcare, that the hospital is using. It needs to have a green light from the finance, of course, and often like a CEO, GM, or like this kind of umbrella. So it's often a board of the people in the hospital. And again, also here, every of those people has slightly different incentives for making decisions. So within this one stakeholder, you have a few sub-stakeholders that you need to understand. I would put it this way.
Exactly, I guess that you hit the bullseye regarding that hospital consists of a lot of sub-stakeholders here. For what you would, for who would you go first in hospital? Or it's like which one you hit?
Yeah, honestly, I would go for whoever is easier, whoever is the easiest to reach out in a certain hospital, because usually, you know, it's important to somehow get a foot in the door, then get into the right door fully. Often, however, not only the medical, but the CIO person was a very important stakeholder, because a CIO at the hospital, they need to make sure that all the systems kind of that it, you know, that the new digital solution somehow fits into the strategy. And what I have learned, at least my experience, was that it's so many people selling anything to the hospitals that sometimes they, unless you get some, I would say, warm introduction or a different way how you get in, they simply put everything into like the same basket of like kind of like spam. So yeah, like, you know, if you have a doctor who works there, like talk to the doctor, you know, and you can like walk your way up. If you know the CEO of some, if you know someone from the IT, you know, go there. If you do not have anyone, I would start with the medical, of course, with the medical part.
Okay,
I think there is a
question. It's about the repository with the stakeholders map of each EU state member's health system. I guess we don't centralize, right?
I'm not aware of, that's a great question, by the way, Jose Maria, but I'm not aware of any repository or anything like this.
I know that you can ask for this in every state. There are this commercial camera, yes, that basically supports companies, and they have some databases. But about this, yeah, I guess no centralized solution here.
Yeah. But maybe something interesting for Civita to build up and start selling.
Exactly. I know that these cameras are already trying to do that. Some of those gives it for free, but some of those already asking some money for databases.
Yeah, I mean, yeah, but yeah, that's a very good point. And how are you like I mean, what's the usual like the stage that you're in, guys? Do you already, most of you have customers or pilot programs, or are you mostly in some kind of like pre-commercial phase? Are you in one market only or in more markets?
Well, in my case, we are active with public hospitals in Portugal, always as POCs, but we have already 16 public hospitals working with us. We are starting next week, in fact, with the Basel City in a project, a day one project that come up, and we were selected to start in a pain management with a pharmaceutical company. And we are also in COVID. We will start with the city of Vienna, a POC, monitoring citizens of Vienna with COVID. So,
City of Vienna.
Yeah.
I live in, so you're going to be monitoring also me. I live in Vienna.
Yeah. So we are in a project with Microsoft and Zuckel, that is an Austrian company, and we will start a POC for 3 months,
cool.
And then we will see if we go to a full process for all, not only for COVID but also for the chronic patients.
Cool. Thanks.
Okay, what about others? Or if we need some warm-up, yes, and it is as first business mentoring webinar, so we will get used to it. Regarding the webinar and answers and questions, of course, huge thank you for Milan for expertise, because I believe that it's really gave value for a lot of companies regarding where to aim regarding value proposition, what's basically our next webinar. Next webinar we have on January 26th about value proposition. And till that, what would be good that we can go through a general mentoring file. I guess all teams knows where to find it. If not, that you can ping me up in Slack, and to reserve your spot for individual sessions with Milan. There are already times. It's January 28th, January 31, and 2nd of February. So the sooner we do it, the better, I guess, regarding the time planning.
Yeah, and maybe maybe one idea. So since we have one more workshop next week, maybe let's blog, but we do not have to use it like the first 10 to 15 minutes of the next workshop. If you have any questions, if like you will digest or process the information like this webinar. If you have any questions about this, we can use the first 10 or 15 minutes of the next workshop to go through those questions first, because we again, I think we have 90 minutes, so it should be enough time to do everything. Christoph, I believe that I will probably send you the slides, and then you will make the slides also available for.
I will post them, exactly. So we will have slides available. This recording for only teams and us and Milan, of course, no other people. And yes, as I already said, that individual sessions time slots are in general mentoring file, so you can find those there.
Cool.
Okay.
Perfect. So in that case, everybody, I thank you for your time and for your attention. Like, hopefully those 90 minutes weren't too long for you. I mean, for me, it felt like maybe 40 or 50, but I'm glad that we were able to answer all the questions as well. Have a great day. I wish you all the best in COVIDX. I mean, it's going to be next quite, I would say, exciting 9 months for you, and I wish you that you achieve all your goals that you set for the accelerator. And Christoph, if you could stay on the line for a bit. Of
course, no problem.
Please. Okay, thanks. So thanks everybody.
Thank you very much.
I'll see you.
Bye-bye.
Have a nice day. Thank you.
Thank you so much. Bye.
Bye.